been an adjunct professor at Carthage College and has worked as the quality coordinator with the Kenosha County Aging and Disability Resource Center since 2010. Helen has also served as facilitator of the Kenosha County Care Transitions Coalition since its inception in November 2011. As Lydia had mentioned, the session is being recorded and will be available in about 2 weeks on the LSQIN YouTube page. Currently, all lines will be muted during the webinar. However, we should have some time for questions and answers after the presentation, so please be fully present and engaged, and make a note of any questions that you have as you may listen. Because Metastar is providing continuing education credit for this presentation, we need to inform you no commercial support has been received. The speakers and planners have no conflict of interest. For CE credits or a certificate of attendance, you must attend the entire session and complete an online evaluation. For Wisconsin and Minnesota social workers, they need to pass a 10-question post-test to earn NASW credit. And we also encourage everyone to complete the evaluation to provide feedback on this session. And this is very important. You will need to verify your attendance today by sending an email to a Metastar email address, which will be provided at the close of the webinar. We appreciate your help with this because we've had to switch webinar platforms. So after today's event, we hope that you will better understand the role that the Aging and Disability Resource Centers, or ADRCs for short, or other similar agencies play within their communities. We also hope that you understand the value of ADRC collaboration organizations in bringing effective community change, and learn about a specific ADRC's involvement in community efforts to reduce hospital readmissions. And this is really where this will be Helen's story and experiences with her and her coalition in Kenosha County, Wisconsin. And with that, I will hand things off to Helen.
Thank you, Ross, and welcome everyone. Aging and Disability Resource Centers are one of my favorite topics to talk about, so I appreciate being able to share that with you today, as well as our role specifically in community impact and positive systems change. So let's get right to it. Next slide, Ross. When we start talking about ADRCs for short, we talk about our mission, and whether we're looking at the local level, as in Kenosha County, or the state of Wisconsin, or the federal level through the Administration for Community Living, you will see some consistent themes throughout that mission. And those are really about helping older adults, persons with disabilities, their caregivers, and the community in general to find and easily access those needed services and provide that trusted source of information. Next slide, Ross. So let's talk a little bit about the history of ADRCs across Wisconsin. And for our partners in Minnesota and Michigan, ADRCs look different in every state. Wisconsin is really probably the forefront of the development of aging and disability resource centers. So if you don't know about the ADRCs in your state, I would encourage you to connect with your area agencies on aging as a starting spot. In Wisconsin, the ADRCs began their development toward the late 1990s, and by 2013, all 72 counties had access to an ADRC, either a county-based ADRC or a regional ADRC. And as much as our core services are the same, we all look a little different, demonstrating that local flavor. So some ADRCs are co-located with a senior center. Others might be in a county building or a storefront, and many are integrated with their aging unit as well. But these really are visible locations throughout the state. In Kenosha, we were one of the first generation ADRCs, and our doors opened in 1999. Alongside the development of the ADRCs were the development of the long-term Medicaid waiver programs. So in Wisconsin, we call that family care and partnership, and those began in the year 2000. And the last piece of the state to be covered by family care was in 2018. So you can see over a 20-year period, the entire state has access to ADRCs, which are the front door into the long-term care Medicaid waiver programs. Okay, next slide, Ross. So this is really one of the core reasons I think ADRCs are so valuable in the community, because if you are an older adult or a person with a disability or a family member who's trying to figure out how to make life work with some of those challenges, it can be very confusing. There's too many silos, there's too many providers, and there's just too much confusion. I was walking past our reception desk this morning, and there was an older gentleman standing there telling our receptionist that his son sent him down for an evaluation. She asked why, and he said, because I'm 82. So she began to unpackage what that meant so she could hand him off to our information and assistance staff, and they can continue that process. But our role really is to reduce the complexity of this sort of still fragmented, still confusing systems. Really, the primary product that ADRCs offers is that reliable, objective, skillfully dosed information. And when I say reliable, I mean that we are working continuously to keep our resources up to date and accurate. When nursing homes close, when assisted livings open, when providers change their names, all of that we maintain and keep accurate. When I talk about objective, I mean that the ADRCs really have no horse in the race. There's nobody paying us to promote their business over somebody else. Our job is about that individual and understanding their needs and preferences and providing the options that fit for them to choose from. And the last thing is that skillfully dosed piece. You know, it's the legacy of Goldilocks and the Three Bears. What is the right amount? We don't want to underinform. We don't want to give people too much information that they get overwhelmed. And really, the relationship with our community members goes on. So we take this first contact and we work with people to get them what they need at that point, and we welcome them to come back to us throughout their journey. And of course, we're very focused on the individual and planning for the future. Okay, Ross. So as much as ADRCs across the state of Wisconsin may look a little different, demonstrating, again, their local flavor, we have some core services that will be the same no matter what ADRC you contact. And as I said before, information and assistance is our number one product. So you can walk through our doors, you can call us, you can email us, and you are going to get prompt response to whatever your question or concern is. You can remain anonymous. You can tell us your whole story. You can tell us a part of your story. You can do whatever is right for you in the moment, and we're going to follow you. If it's just I need the phone number for Meals on Wheels, that's great. If it's I just came home to visit my mom for Thanksgiving and holy smokes, I didn't realize, then we're going to go into a bigger conversation with you. At that point, we may do what we call long-term care options counseling, where we're going to offer a face-to-face visit. Primarily, we do that in the home, but we can meet with people in our office as well, where we're really going to take some time and understand what the situation is, what the needs are, what the wishes are, and go down pretty much one of two paths with folks. One path is that private pay path, because we have no income eligibility, so we do serve everyone. And if you're not eligible for the Medicaid waiver programs, then we want to talk to you about how to conserve your resources, how to make the best use of your resources, what kinds of creative options may be for you, what little grants exist, what volunteer resources exist. If you do meet or look like you meet the eligibility for our long-term care waiver programs, Family Care Partnership and IRIS, and PACE, also in Wisconsin, then the ADRCs are that front door into starting that process. Our role is to do the functional screening for those programs so that we know that people are meeting that nursing home level of care. And then we also work with our economic support or income maintenance staff to ensure that the financial eligibility is met and people are Medicaid eligible. Once that has been determined, then we roll into what we call enrollment counseling, where we talk to you about the different programs that are available in our own areas. Again, Family Care Partnership, IRIS, are our main long-term care waiver programs, and we help you understand the difference. And then once you pick that program that makes the most sense to you, we help you understand which providers are available for those programs, and you then choose those providers. So that is the large bulk of our services, but also with it comes a number of other things that we have to offer people. So when we get that phone call that says, I'm going on Medicare and I don't understand my choices, we're going to refer to our benefits counseling, to our Welcome to Medicare workshop, or we're going to, for that person that calls and says, I applied for Social Security disability and was denied, we're going to refer to our disability benefits counselor. We also provide health and wellness and prevention services, those chronic disease self-management classes, healthy living with diabetes, and falls prevention. All of those things are available through the ADRC. ADRCs also do some kind of dementia services in one way, shape, or form or another. Some ADRCs have actually a dementia care specialist on staff, and that person does consultation with families and really works with the ADRC to be dementia capable, as well as working with the whole community to reinforce dementia-friendly communities. The next thing is transition services, and those are for individuals who are aging out of the children's services. So we start working with folks who are 17 and a half to make sure that that transition into the adult services is smooth. And lastly, and this is where our Care Transitions Coalition work lies, we are very involved in systems advocacy because we are so interwoven with our community. Okay, Ross. So if I were going to sum up the role of the ADRCs in our community, it would be we serve everyone. Anyone in the community can call us, and you can call us about everything. We're going to, if we can't address your need, we're going to get you started in the right direction. That reliable, objective source of information is so important to people, to be that trusted entity. And to help you evaluate what your options are, as well as to help you be wise about conserving your resources and making good decisions that will help you avoid expensive long-term care. When I talk about the ADRC, I talk about, it reminds me so much of my mother's purse. And I don't know if you had a mother with a purse like this, but that thing was magic. I'd be having my stomach growling in church on Sunday mornings, and that woman would pull out a dinner roll from the supper club she and my dad ate at last night. There was needle and thread in there when the button was about to pop off. There were Band-Aids. There were Dentine because I forgot to brush my teeth. There was really anything that you needed inside of my mother's purse. And that is the way that I think about the ADRC as well. I can't imagine any reason that someone wouldn't call the ADRC when they are dealing with issues and challenges around aging or disability. Next slide, Ross. So this top paragraph is from our state. ADRCs are highly visible in their communities. ADRC employees are local experts in aging and disability issues. They perform outreach and education to build knowledge, reduce stigma, and shape attitudes about the value and opportunities presented by older adults and people with disabilities. They identify unmet community needs and gaps in area services and work within their communities to build local resources, form new partnerships, and expand their reach. So you can see how much and how important it is for the ADRCs to be really a part of and involved in their communities. I'll give you a couple examples from Kenosha. We have a loan closet because we identified that as a need. So we are working constantly with everyone in the community who needs to borrow some durable medical equipment. We show up at our Pride Fest every year. We support a Hispanic Heritage Month event. And in terms of coalitions in Kenosha, we have our Care Transitions Coalition, which Ross told you has been functioning since 2011. We have a Falls Coalition, and ADRCs across the state also collaborate. So Brown County had a wonderful intervention with their EMS folks, which Kenosha stole with righteousness. And they were very, very kind in helping us get that up and going. So when someone falls in the home and EMS shows up, if they are not transported to the hospital, the EMS folks offer to have the ADRC contact them for more support or information on falls prevention. And then we get that contact in the morning. We also have a caregiver coalition because they're such an important part of our system of care and our aging network. And then we have a long-term care workforce alliance that we are involved in for those private caregivers. So I hope that you get a sense of how much the ADRC is really woven into the community and into the systems of care for older adults and people with disabilities. Okay, Ross, let's move on. So, our transition of care story. How did we get started in this ballpark? And I would say to you that it was one of those perfect storms where the planets all aligned. I went to a national conference in Baltimore in 2011 because of a grant that we had, and when I got there, I heard all about this thing called Care Transitions. And Dr. Coleman was there presenting his model, and it was just a really inspiring opportunity. So I came back to Kenosha and said, we need to get involved with this. From there, we had sort of a traditional and non-traditional approach to reaching out to our hospitals. Because we have such a long history of collaboration, our director served on one of our hospitals' acute care for the elderly advisory committee, and she used that as the mechanism to begin the conversation. The non-traditional approach for the other hospital was the fact that the CFO, that his wife was in my book club. So that conversation started over a glass of wine before book club. And I guess my message here is that it really doesn't matter. There's no right way to go about creating these connections. There's just whatever way works. And then the last piece was that at that point, Medistar had received its scope of work to support these community coalitions. And we had our first meeting at the end of November. I do say that Kenosha was the first coalition in Wisconsin, and so far nobody's disagreed with me, so I think that's true. From there, next slide. We had to figure out our structure. You know, how are we going to work together? We had 2 hospitals in our community, which is not a lot, certainly not compared to Dane or Madison. And they hadn't had a really long history of collaboration, so it was very tentative beginning. And because of that, I think that the coalition really decided it wanted to stay small, but have enough people at the table that we were getting input from every area that we needed it. It was really offered in the beginning and gratefully accepted by all of our members to have the ADRC act as the facilitator. We had that resource available, and I think our sort of neutral presence in the community was really helpful in that way. So when we started, we had 2 hospitals, 4 skilled nursing facilities, pharmacy, hospice, home health, supportive home care, independent living center, community-based nonprofit, managed care organizations, and then we've always really been committed to having a consumer at the table as well. So once the organizations were chosen, and they were really chosen through the social network analysis that was provided to us by Medistar, then we said to those organizations, you pick who should be at the table. But that was really an important part of our success, is who those people were. We made it very clear from the get-go that we needed change agents at the table. So it was not marketers, as valuable as they are. These were people who were either administrators or clinical leads who really could impact their systems, who could provide data, who could also have a passion around the work as it connects to the people we serve. We worked really hard on our charter. We continue to use our charter all of the time. We review it regularly. And then we had some really important structure for our coalition as well. Regular meetings, agendas. We have several work groups. And then because we were small, we wanted to make sure we were being transparent with the community about our work. So we have an information sharing system through our Google site, which is available to anyone to go and look at what we're up to, what we care about, what we're learning, who's participating. Okay, Ross, now you can flip the slide. If you go to our Google site that's listed there, there's a document called our overview document, and that will show you everything that we have attempted since the beginning. We had probably, I don't know, maybe 20 interventions that we've tried over time or things we've invested in. But Ross and I are going to talk specifically about these 4. Meals on Wheels, the PACT program, our end-of-life work and advanced care planning, and options counseling, which you all now understand because we covered it several slides ago. So let's start with Meals on Wheels. As I had shared with you, we were all really captured by Dr. Coleman's care transitions model, and had really hoped to get it started here, but that just didn't work. And in 2013, we had a little bit of money that we could play with from a grant that allowed us to hire a very part-time nutrition coach. And for a year, she worked with folks who were coming out of the hospital, focused on making sure their nutrition was good, and we included with that a free week of home-delivered meals, making sure they were doing their follow-up at the doctor, and making sure that their medications they were accessing their medications and understanding that. So after a year, it was a successful pilot, but we knew it was not going to be ongoing. And she had served 70 people, and what we can tell you is that 95% of them had no readmission, 30-day post-discharge. So after the program ended, we were wondering just about the meals themselves and how important those might be in reducing admissions or readmissions. So in our wonderful partnership with Medistar, we started collecting some data about that. And I'm going to turn it over to Ross to share that data.
Thank you, Helen. So over the years, especially since we've been working with the Kenosha Care Transitions Coalition, they've done a really great job of understanding the importance of data and really being able to leverage that data to track effectiveness of their working projects. Now, when you want to collect data and you want to use the data to do this, it does require some extra work, but without the collection of data, you really can't gauge the impact of your community projects. So for certain coalitions, especially with the coalition in Kenosha, wherever they have these projects, wherever they are deployed, members from those organizations do a really great job at capturing information for community beneficiaries that become involved in that work. So we use this information that they collect, and we take it and we at the LSQIN can then analyze the effectiveness of these projects through our access to our Medicare claims data set. So for this, not only the Meals on Wheels project results, but for the other, at least two of the other projects that we're going to show today, we use the same methodology, and it's a very simple methodology. Our data analysts calculate admissions and readmissions per community beneficiaries who participate in these community programs such as Meals on Wheels, and we compare admissions and readmissions for two separate time periods. Admissions and readmissions 6 months before enrolling in the program, and then admissions and readmissions 6 months after enrolling in the program. And we hypothesized that beneficiaries involved in these programs would have fewer preventable admissions and readmissions because these programs do address specific health needs and would thus result in more positive outcomes. So looking at the results from the Meals on Wheels project, there were 56 Kenosha County beneficiaries enrolled in the program that could be analyzed through the Medicare claims file. We did see a reduction in admissions per beneficiary after enrollment in the program from 0.68 per patient before enrollment in Meals on Wheels to 0.46 per patient after enrollment. So that was positive. However, we did see a slight increase in readmissions per patient after enrollment in the program, but the 0.13 readmissions per patient after enrollment is still a very small number and still could indicate that Meals on Wheels has a positive impact, especially when you look at the baseline for readmissions. The pre-enrollment was 0.07, which is extremely low to begin with. So it could be seen, it would have been difficult to have even fewer readmissions for those beneficiaries after enrollment. And I'll swing it back to you, Helen.
Thanks, Ross. One of the other things that I think it's helpful to understand about the Meals on Wheels participants is these tend to be frailer people. You have to be homebound in order to be eligible for the Meals on Wheels program, and you really can't be able to prepare your own meals, and there has to be some level of risk in terms of nursing home. So The next project is the PACT program. And when I said to you a couple slides back that the people who show up at the table are so important, this is one of those cases where we just got very lucky with Phil Burse, who came to the table early on and is the owner of a local pharmacy. And he came with enthusiasm and commitment and professionalism, and he really wanted to do this particular intervention to help readmissions and, of course, health in general. So the PACT program was developed and has continued to function and is a really important resource in our community. And it is a packaging program, and you can see on the slide there that the medications come in a roll, and you rip off these packages based on the time of day. The PACT program also offers reviews with the pharmacist. They make sure that the medications are exactly correct, and they offer free home delivery as well. So this has been a valuable resource, and Ross is going to tell you about the data.
So when looking at the PACT project, we can see that it did show effectiveness in reducing admissions after enrollment at 0.59 per patient when compared to the 0.82 admissions per patient before enrollment. Readmissions for the per patient 6 months pre and post were identical at 0.8. I'm sorry, 0.18.
Thanks, Ross. So when I was talking to you about our structure, I had mentioned our work groups. And one of the work groups that came out of some enthusiasm from the members of our coalition is our Advanced Care Planning work group. And this really was directly related to our early root cause assessments, around chart reviews and other things that we used, which identified end of life as one of those transitions that really we were not feeling very successful about in our community and saw the need for improvement there. So this work group got together in January of 2014, and we started to really focus in on this whole notion of advanced directive to try and broaden the conversation around end of life, to normalize it, to make it be part of what we do as healthcare providers, as social service providers, that this is a normal thing to talk about. And we really tried to bring that conversation as far upstream as we can. For those of you who aren't from Wisconsin, Wisconsin is not a next of kin state. So our work group really recommends that anybody over the age of 18 have a power of attorney for health care completed, because decision making is not a guarantee. So with that being said, we've tried a number of different things to widen this conversation. One is that we coordinate an annual event for National Healthcare Decisions Day, which is April 16th every year, the day after taxes are due. We created a toolkit to ensure a consistent message across our participants and anybody in the community who wants to use our PowerPoint or our other tools is welcome to use them. There are a lot of inconsistent messages around what advanced care planning means and what a living will is versus a power of attorney for health care versus a do not resuscitate, and how it all fits together. Because Kenosha County, and I should have pointed this out when we had the map up, but we are the county in the far southeast corner of the state, so we border Illinois, and many of our providers cross that border. And Illinois has a very different set of rules around their advanced directives. So we've had to talk with providers when we see they are giving inaccurate information around powers of attorney or decision making, because it's true for Illinois, which is where they may be based, but not true in Wisconsin. So we're really committed to that consistent messaging. And then we've also developed a 3-part series that we offer employers. The Humana Go 365 will give the employees points for completing the series. The first 2 parts of the series are education and helping people think through what it is that they want in their documents. And then the third session is completing the document. We all serve as witnesses, and that's been a really successful way to expand the conversation. Now, this is one place where we are not so great about collecting data. We, as a coalition, really were not a bunch of data geeks at the table when we started, but we have come to, over time, value and depend on data. And we all believe now that if you don't measure it, it didn't happen. But we don't have a great measure for our advanced care plan projects. Ideally, we would like to know how many people in Kenosha County have a completed advanced directive, and we don't know that. The Aging and Disability Resource Center every year tracks how many powers of attorney we've helped people complete. We have a Wednesday morning standing appointment where you can come in and we'll help you go through it. We've tracked how many people attend our National Healthcare Decision Day. One of the things we've done with that event is we've included local celebrities who have completed their power of attorney through this process, and have this past year done a lot of Facebook posts. So we've looked at the reach for those. And one of our local hospitals has some information, but this is a place that we need to clean up. I am hopeful that now that Epic is part of both of our hospital systems, that we will be able to get better at this. And the second thing that we've done is we've actually added the question, do you have an advanced directive, to our community health needs assessment. So that will help us look at, over time, how many people are completing those documents. Okay, last one. So you all understand now options counseling is one of those core services that is offered by the Aging and Disability Resource Center. It is that interactive decision support process where we, in a face-to-face interaction, are helping people, we're unpacking what their needs are and helping them look at what options are available to meet those needs. And it may be a one-time conversation, and it may be a couple of conversations or conversations over time. But we began to wonder, is there a way to look at that options counseling and its impact on people's health? Specifically, have they been to the hospital or have they been readmitted? And what we had to do is we had to just focus in on the folks who did not enroll in the long-term care Medicaid waiver programs, because that would be measuring their impact more than that conversation. We just looked at the folks who, for the most part, stayed on that private pay track or for whatever reason decided not to enroll in the programs. So Ross is going to tell you about that.
Well, it's a very good question, Helen, because there is a way that we can track admissions and readmissions for these folks that receive the options counseling service. So the results of the options counseling project did show a very positive impact at reducing both admissions and readmissions. As you can see on this table here, admissions enrolled for beneficiaries 6 months prior to involvement in the program fell from 0.78 per beneficiary to 0.44 admissions per beneficiary in the 6 month period after participating in the options counseling program. Likewise, readmissions also did fall from 0.23 prior to 0.06 post-enrollment. So by the data results, the options counseling project was deemed very effective. So I'll pass it back to you, Helen.
Thank you. So when we look at the future, I'd really like to say we have a clear plan, but the only clear plan we have is to keep going. It's, you know, it really requires whatever the synergy of the group is to determine what we're going to tackle next. And people have different passions and motivations and things that they're concerned about, and all of that matters, and everyone at the table matters. So out of that, we get some sense of direction. We also look at our data all the time. You know, where are our problems in the community? What are those areas that need further exploration? We just recently got some data that tells us that hypertension is a top diagnosis for admissions and readmissions, and it's not making any sense to our providers, so we're going to look further at that. We keep in mind fairness and inclusion. Everybody needs to contribute. Everybody needs to have a sense of meaning and purpose in what we're doing together. We do a lot of inspired stealing from our wonderful partners across the state. We have 10 other coalitions, and we share liberally with each other. So that, you know, may contribute to what we think might be the next thing that we're going to focus on. And then we always have to be, you know, surrender to those forces beyond our control. Staff changes is a real challenge, and it shifts some of our work on a regular basis. So just keep going is the answer to our future projects.
Thank you, Helen. So if we want to look at coalition successes, we just kind of made a note of some of the top successes for the coalition. So since its inception, the Kenosha County Coalition has proven to be an effective community collaborator that has produced tangible benefits, not only to the group and the organizations involved in the coalition, but as the community as well. And we see these benefits from many of the active coalitions throughout the three-state LSQIN region, but these are some of the more notable achievements that we've seen in Kenosha County. So the first one is the strengthening of relationships between the involved members and organizations in the coalition. This is one of the more natural benefits of participating in a community coalition, but we really do see the building of relationships between people representing, you know, multiple and diverse organizations and setting types. Getting to know someone and interact with them face-to-face and collaborate, these benefits continue outside of the coalition meetings and can lead to improved relationships between those diverse groups of organizations. The coalition has also developed a very clear purpose or mission, and the roles and duties for participation are well understood as well. Managing large groups and projects can be difficult for a number of reasons, and members can easily lose enthusiasm, but Helen does a great job at communicating the purpose of the group and keeping these members accountable so that everyone's involved. Responsibilities are fulfilled, and group projects remain on schedule and are completed within a timely fashion. So her roles and responsibilities as the coalition facilitator are known and understood to the group, just as the roles and responsibilities of the rest of the coalition membership. So this is important to note because it creates efficiencies and really makes the coalition efforts worthwhile. And finally, the last two bullets kind of go hand in hand and probably are the most important successes that the Kenosha County Coalition has seen, and that is the improvement in the community outcomes. So quantifiably, we have seen a significant reduction in preventable admissions and readmissions, across the board for Kenosha County Medicare beneficiaries since the coalition began work in 2011. And more generally speaking, the coalition efforts have helped strengthen community organization, communication, and relationships, improve coordination throughout the care continuum, as well as patient-caregiver self-management. So it would be safe to say that these coalition successes have led to the quantifiable improvements of the reduction of admissions and readmissions throughout the community.
Thanks, Ross. So some of the lessons learned I would share with you is, first of all, I think the ADRC really is a perfect choice as the convener and facilitator because we have no competitor in the room where the hospitals are competing against each other or the hospices or the home health agencies. The nursing homes all have that level of competition underneath the surface, which is understandable. But in our role, we can just really reinforce mission and vision that regardless of that competition outside this door, inside, we share the care for the patient and the improvement in systems countywide. I would also say that, having one consistent facilitator is good. Now, there are many communities where there aren't enough resources for that, and people use a sharing model, and that works for them. But to have one place where there's the work is being documented, there's follow-up, I like to call nagging with love, I'm able to delegate things and kind of just see the plates keep spinning. I think that has been a gift to our coalition to be able to have that resource. And like I said before, getting the right people at the table is so important, and keeping them there by engaging them and making sure that the work is meaningful to everybody and that there's a role, or duct tape, whatever works for you. And the other lesson I would say is when I look back on our overview document that has the history of interventions on it, there are some that really did not work at all. And that is okay because we learned from them and we moved forward, but we tried something. And that whole do something, try something thing is the piece that I think keeps people coming back. Lastly, I also think it's important to refresh and renew. There was a few years back where I felt like we were kind of moving into a slump, and I went and did visits to every organization that was at the table, and I had one-on-one conversations with them, and I talked about recommitting and what it is they thought they could bring to renew our efforts. So however you continue to be refreshed and renewed, even if it's just going over your charter and reminding each other why you're there, that is an important thing to keep that positive forward motion going.
Thank you so much for sharing, Helen. Helen, I just want to say, Helen is an exceptional partner with us here in Wisconsin, and as well as, her partnership with their coalition with the folks in Kenosha County, and we're very lucky to have her. And I am very appreciative and grateful that you were able to share your experiences with us today. It's been very helpful. So
Thank
these
you,
next
Ross.
couple of slides, you're welcome. Thank you. These next couple of slides provide some information about the future organizational makeup of the LSQIN and the new CMS focuses for the next 5 years. For 2019 to 2024, CMS has outlined these 5 broad priorities for the Quality Innovation Network Quality Improvement Organization, or QIO program. As you can see, care transitions or care coordination will continue to be one of the main focuses, just as it was for this current scope of work that we are finishing up. Lake Superior's Lake Superior QIN's partners, Empro, Medistar, and Stratus Health would like to thank you for all your hard work to advance the health and health care of your patients with us for these past 5 years. As we look to the future of improving quality on behalf of Medicare beneficiaries, our 3 organizations have entered into a new partnership called the Superior Health Quality Alliance, or Superior Health for short, which is strengthened by the addition of the Illinois Health and Hospital Association, the Michigan Health and Hospital Association, the Midwest Kidney Network, the Minnesota Hospital Association, and the Wisconsin Hospital Association. We each have success driving achievement of Medicare Quality Improvement Program goals as either a quality improvement organization, a hospital improvement innovation network, or end-stage renal disease network. Superior Health members currently improve healthcare in Illinois, Michigan, Minnesota, North Dakota, South Dakota, and Wisconsin, and experience improving healthcare quality nationwide. As Superior Health, we aim to support the Centers for Medicare and Medicaid Services in improving the quality of health and healthcare delivery for healthcare consumers, providers, and communities in our region and across the United States. So we just wanted to provide you guys with that update because there will be some branding changes in the near future. So once again, I just want to thank Helen for sharing this information and her story with us today. And I think we may have a couple minutes for some questions. But since we have a different system than we normally have, Lydia will come back on and explain the options for submitting questions.
Hello, everyone. If you do have questions today, please use the chat function and send the questions to everyone. We will then go through the list and get to as many questions as possible. If you want to say your question out loud, just please leave a note in the chat saying this, and once we get to you, we will unmute your mic. So if there are any questions, please submit them now.
And while we just wait maybe for a minute or two for those questions to come in, I wanted to provide this information regarding the continuing education credits. So all participants today must send an email by the end of the day today, to this email address that's displayed on this slide. So it's continuing-ed@medistar.com. You need to send an email today to have your attendance recorded for the session, receive an evaluation link, obtain a certificate, or obtain an educational credit. So you will be sent an evaluation link by the end of the day on June 26, 2019. That is tomorrow. If you do not send an email today so that we can record your attendance, we won't have your participation on record, and we would not be able to help you with your future requests, such as needing a certificate. So this is your only opportunity to report your attendance, and once again, we apologize for the inconvenience, and we really appreciate your help with this whole process.
All right, it looks like we don't have any questions coming through, so I will leave the meeting open for the next 5 minutes so that you guys have a chance to write down that email and let me know if you have any issues getting that email written down so that we can help you get that email off to continuing education. They do need to get an email from you today so that they can send you the evaluation link so you can get your educational credit.
Thank you, Lydia. And that concludes today's webinar. We thank you for your attendance and participation today. We also, again, want to encourage you to complete the evaluation for today's event, especially for those attendees, once again, wishing to receive the continuing education credits. This feedback that we gain, we use this to improve upon the quality and content of these offerings. And as a reminder, the recording for this webinar will be available on the Lake Superior QIN YouTube page at www.youtube.com/ /user/LSQIN. This will be available on that YouTube page in a few weeks. Thank you for your time and have a great day.